Hi, Simon Smale. I've been asked to talk to you about inflammatory bowel disease, immunosuppression and biologicals, and so I'm going to talk to you for 20 minutes, there or thereabouts, on those things. Hi folks, here we go. Okay, this is going to be a whistle-stop tour and I may miss bits out. I'm going to talk to you about thiopurines, azathioprine and 6-MP, methotrexate, a bit about cyclosporin and tacrolimus. I'm going to skip mycophenolate because there are no real data on it. I'm going to talk to you about infliximab and biosimilars, and in terms of all of them I'm going to try and mention something about the mechanisms, the indications, the tips on optimizing them, and perhaps one or two words on side effects. So azathioprine and 6-MP, essentially it interferes with, both drugs interfere with RNA and DNA synthesis. Azathioprine is metabolized to 6-MP. Lymphocytes are unable to recycle purines, unlike other cells, and therefore they're, if you like, disproportionately affected by the interference that azathioprine and 6-MP pose to the purine biosynthesis pathways. Lymphocytes also seem to undergo apoptosis via CD8-28 transmembrane signalling modulation via RAC cell signalling when exposed to azathioprine, although that's part and parcel tied up with the purine metabolism. In terms of the indications, they are there. It's an unlicensed drug. It's used both to induce remission and to maintain remission. It's a steroid-sparing, both are steroid-sparing agents, and should be considered in people with 2 or more relapses a year, or who have early relapse following tapering their steroids, or who are known to have complex Crohn's disease. Cochrane review suggested the number needed to treat to induce remission was 4, and the number needed to harm was 14 at 16 weeks. And similarly, in terms of maintenance of remission, the number needed to treat is 3 in Crohn's disease and near 5 in UC, and that's both from Cochrane analyses. Considerations. Again, both drugs are safe in pregnancy. Azathioprine is usually given at a dose of 2 to 2.5 milligrams per kilogram per day. Mercaptopurine slightly less, 1 to 1.5 milligrams per kilogram per day. It's suggested that those who have a low TPMT should be started on a lower dose of drug, perhaps very sensibly, and that you don't give it to people who don't have TPMT because you'll kill them. I have seen that happen once in a previous life when we didn't do TPMT testing. It's suggested people on allopurinol should take 25% of the dose, essentially because allopurinol blocks the one of the pathways and therefore leads to a greater accumulation of the active metabolite, and therefore you don't need quite so much. And doses should be reduced in people with liver and renal disease that's severe enough to affect the metabolism. In terms of optimization, clearly when you start patients, you're going to do blood tests weekly for 4 weeks, alternate weekly for 2 months, and then every 2 or 3 months. It's recommended that if people develop infection, or they're admitted to hospital unwell, or if they're getting unexpected bruising, bleeding or fever, they should stop the medicine. If patients relapse on therapy, then one needs to think about optimizing the dose. First of all, are they taking the stuff? Secondly, they should undergo metabolite testing, and most of our patients on azathioprine undergo at least annual 6-TGN and MMP levels, and that looks to see that their levels are adequate. But you also need to look at their lymphocyte count to make sure it's more than 0.5, and their MCV shouldn't really get above 115, although I've got one patient who also drinks a bit, who has an MCV that's always more than that. In terms of azathioprine, you may need higher doses than 2.5 milligrams per kilogram per day, or greater than 1.5 milligrams per kilogram per day for mercaptopurine. Use the levels. If things don't work out, then we consider methotrexate, anti-TNF drugs, or surgery. In terms of methotrexate, again, it works on the metabolic pathway of folic acid and inhibits production of thymidylate purines and methionine, and leads to accumulation of adenosine, which has lots of anti-inflammatory properties. In so doing, it inhibits the production of interleukin-1, interleukin-2, interleukin-6 and 8, which are all pro-inflammatory. In terms of the indications, they are very similar to the thiopurines, but generally we use thiopurines first, probably out of habit in Crohn's disease, and they can also be used in combination with anti-TNF agents. There's some evidence that you get decreased antibody formation to the anti-TNF agents on people on methotrexate, and it's got some role in fistulizing disease. It's also used to induce remission in ulcerative colitis, although it must be said that the data in that regard is much more frail than it is for people in Crohn's. So in Crohn's disease, after inducing remission, 65% of patients taking 15 milligrams IM remain in remission after 40 weeks, and that's pretty good. So don't give it in pregnancy or liver disease, but particularly not pregnancy, it's teratogenic. Again, monitor the bloods. Take them weekly for 2 months, then monthly. And again, stop them as you would with the people on thiopurines if they get fever or bruising or become unwell. It's suggested that 25 milligrams orally or subcut or IM once weekly over 8 to 12 weeks to start with may be more effective, and that then patients should take 15 milligrams weekly as maintenance therapy and switch back to IM if that works better for them. Obviously, patients need to take it weekly, not daily, because you get much more side effects, and they need to take folate on the days that they're not taking their methotrexate. In terms of tacrolimus and cyclosporin, these are calcineurin inhibitors. Now, calcineurin essentially catalyzes the processes associated with T cell activation. If you inhibit that by virtue of blocking a protein called an immunophilin, they block the effect of calcineurin, and this results in reduced interleukin-2 and reduced T cell proliferation and hence reduced inflammation. Now, in terms of tacrolimus and cyclosporin in Crohn's, there's only 1 of 4 trials demonstrated efficacy of oral cyclosporin for luminal disease, and therefore it's not indicated. There are 3 small case series suggesting some benefit of IV cyclosporin, but they're not randomized controlled trials. In Crohn's disease, oral tacrolimus, again, there's not much data, a couple of uncontrolled studies, and there's a small placebo-controlled trial suggesting efficacy in fistulating disease. However, the response is kind of lost very soon after you've stopped it. Ulcerative colitis, we all probably are familiar with the role of cyclosporin being used to induce remission in acute severe UC in those intolerant or refractory to steroids. Basically, 76 to 85% respond by day 8, with a median response at day 4. And about 10% still, however, require colectomy. In terms of tacrolimus in that, about 70% who achieve therapeutic levels respond by 2 weeks, but it's not generally used for acute severe UC. It's generally used for people with active disease in relapse, but who don't require inpatient admission. That's generally given orally. For maintenance therapy, cyclosporin is rarely used because we obviously try and switch people to thiopurines once they've escaped from hospital. However, about 60 to 90% requiring colectomy over 7 years for those who do bridge to thiopurines after receiving it as an intravenous therapy in hospital. And similarly, tacrolimus is rarely used for maintenance therapy, though one study has shown that there's a partial response in about 50% over a 3 or 4 year period. There is no role for either of these drugs in preventing relapse. So onward, as time flies on. So in the cyclosporin, calcineurin inhibitors, you need to think about the cholesterol and magnesium, because if they're low, they've got a much greater risk of both seizures and of other side effects. You need to check their uric acid, liver function, and their blood pressure, because hypertension is a big side effect of cyclosporin. You also need to check their renal function, because that's the first thing that goes off when people's cyclosporin levels are high, and you'll get Usinase back much quicker than you'll get a cyclosporin level back if you're in a peripheral hospital. You also need to be sure that their immunity is reasonably intact to start with. and get them to avoid grapefruit juice because that interferes with the metabolism of both those drugs. So in terms of optimization, there's good evidence for using 2 milligrams per kilo per day rather than 4, which is what we used to use. And in terms of dosing, we usually give IV cyclosporin for 3-4 days, up to 7 before switching to oral dosing in 2 divided doses of 4 milligrams per kilo per day. We usually continue that until they escape from hospital and switch them when they're established on thiopurine. Obviously, it's worth giving steroid enemas and 5-ASAs if topically if you can. And you should check inpatient trough levels on alternate days, although you may find that you get your urea and you can ask the patient about headaches and shakes and look at their blood pressure long before you'll actually get the cyclosporin result back and make adjustments accordingly. In terms of tacrolimus and cyclosporin, you need to think about using a prophylactic cotrimoxazole to prevent PCP. Mycophenolate, again, there's very little evidence. People do use it. I personally am not a big fan. It works by blocking synthesis of DNA and RNA, and again, selectively, therefore has greater effects on lymphocytes because they can't salvage their purines. There are small studies. Main side effects, nausea and diarrhea. I must confess, not a big fan. I'll whiz through those. I'm going to talk about biologicals now, and general considerations in terms of the biologicals. You need to make sure they've not got rip-roaring infection in terms of TB or other sepsis in their abdomen or elsewhere. You need to consider that they've got heart failure. Most of the mortality in people receiving biologicals is as a result of sepsis and in the elderly. And you need to think about whether they've had demyelinating disease because you don't want to be recrudescing their MS. Similarly, there's a slightly increased risk of lymphoma in people having biologicals, and you don't really want to give it in people who've got a history of lymphoma. And if they're having or have a history of oncological disease, then you need to think about whether you should be having a discussion with their oncologist. In terms of tests you want to do, there's a list of tests there. I'm not going to go through the detail. You can have a look at that in more detail on the web, but the ECHO guidance suggests that. Now, in terms of anti-TNFs for Crohn's disease, they all work on TNF-alpha. There's a big surprise. So, infliximab is a chimeric human murine anti-human tumor necrosis factor monoclonal antibody. It binds to tumor necrosis factor and inhibits binding of TNF-alpha with its receptors. Adalimumab works in a similar way, but also there's some evidence that in vitro it lyses cells expressing TNF surface on the surface. Sertolizumab is a pegylated TNF-alpha, and therefore its activity and its presence in the body is more sustained. You get more even, less peaks and troughs. Obviously, that may have some theoretical benefit as well. So, moving on. In terms of Crohn's disease, indications are for moderate to severe Crohn's disease, equivalent to perhaps a CDAI of greater than 300 or a Harvey-Bradshaw score index of greater than 7, where there is either a poor response to other therapies, particularly steroid refractory disease, or despite immunomodulator use, or where there's widespread active disease, particularly with adverse prognostic factors such as fibrosing or fistulating disease. So, in terms of response and remission, all three, Inflix, Humira, and sertolizumab, have been shown to induce response and remission. Infliximab combined with azathioprine is more effective than infliximab or azathioprine alone to induce remission. And the Accent 2 study confirmed that infliximab was beneficial in perianal fistulating disease. 69% responded at 14 weeks, which, when one considers when I was a registrar pre-infliximab days, that was something we'd only dream of. 36% had complete closure, and 46% had greater than 50% closure at 1 year. That was pretty remarkable at the time it first came out. Rates of fistula remission following treatment for 1 year with adalimumab are similar, although velocity of closure appears to be slower. So maybe that infliximab should be preferred in people with fistulating disease, perhaps. That was shown in the CHARM study. And in terms of anti-TNFs for Crohn's disease, again, for maintenance of remission, all three, infliximab and sertolizumab, have all been shown to maintain luminal remission. It should come as no surprise. Both infliximab and adalimumab are efficacious at maintaining remission and should be provided for at least 1 year. So, in terms of other uses, we use it to prevent relapse post-surgery, and they've been demonstrated to have efficacy in maintaining surgically induced remission. Chop it out and then put them on infliximab. And we do that particularly with more complex patients, but consider it these days in an increasing body of patients. It reduces endoscopic relapse at a year from 85% to 9%, which is pretty remarkable. There are few studies that have reported the effect of anti-TNF as post-operative Crohn's disease prophylaxis, but those are coming. Other uses include for extra gastrointestinal disease and symptoms, but overall you need to consider that hospitalisation and surgery rates are reduced by about 30% for people taking anti-TNFs. Biosimilars, just a couple of words. Echo have really kind of came out against biosimilars, perhaps surprisingly, but then again, many of their great and good may well be working in laboratories that have done quite well from the development of biologicals, and maybe one should therefore take that into account. However, the European Medicines Agency and MHRA, who of course are government bodies and therefore may look upon things as a way of saving money, have also issued a statement in support of biosimilars. My personal view is probably that they are fine. The makers of biologicals have altered the drugs over the years anyway, and biosimilars are very similar. There's a surprise. Make your own minds up about that. Now, in terms of anti-TNFs in ulcerative colitis, infliximab, in terms of use for looking at putting people in remission or response to disease, Act 1 and Act 2 evaluated the efficacy of infliximab in moderate UC refractory to 5-ASA or corticosteroids at week 8. And there was a response of 65 to 70% and remission in 35 to 39%, with mucosal healing in the majority. After 1 year, colectomy rates reduced from 17% to 10%. And that's pretty good, I think. Certainly if you're the person having a colectomy, if you're a young woman or a young man, that's I'd be glad not to have my colon out. In terms of its use of anti-TNFs in acute severe colitis, infliximab is an effective second-line therapy in acute severe UC. And so you'd use it instead of cyclosporin if people aren't responding to steroids, and again as a bridge to thiopurines. So you give it at 0, 2 and 6 weeks whilst you get their TPMT status sorted out and start them on thiopurines. Colectomy-free survival is improved in people taking biologicals for induction of remission. And broadly, the adverse events are similar to cyclosporin, although there's no trial evidence to support the use of anti-TNFs over or above cyclosporin or instead of cyclosporin. They're pretty even. There are 1 or 2 studies using it as a third-line therapy once people have had cyclosporin. And colectomy-free survival at 3, 12 and 36 months has been reported at 60, 40 and 30%, with remission in only 30%. Moving on. Adalimumab, again, a usual dose, 160 80 or 80 milligrams at induction dose, has been shown to be superior to placebo, with remission in 18.5% at week 8. Separate trial demonstrated superior responses in anti-TNF naive patients at the same time point, 21% went into remission. However, it has been said that its echo have suggested it's not appropriate to compare infliximab with adalimumab in terms of those trials, because the endpoints were slightly different and had different levels of rigour. So you can't say one's any better than the other. Golimumab, again, that showed clinical remission in 19% compared with 6% placebo in week 6. Whistle through this. essentially, again, steroid-free remission in a subset receiving corticosteroids of 24% versus 10% who are on infliximab. That wasn't very well conveyed. These results improve with concomitant thiopurine therapy. So the success trial showed corticosteroid-free remission at 16 weeks was 39.7% of patients receiving the combination of infliximab and azathioprine, compared with 22% receiving infliximab alone, or 23.7% receiving azathioprine alone. Essentially, 2/3 of patients had a response and 2/3 had a sustained clinical response in terms of the maintenance of remission. Adalimumab had similar rates. So, optimization. We obviously need to demonstrate a clear therapeutic response. These are expensive drugs, and if there is no response, we should stop using them. There needs to be, and according to NICE, it should be annual reassessment of people's response to these drugs and whether they either should be stopped or whether they need to change the dose to make sure that we are using them effectively. And that should be in an objective fashion with endoscopy and histology and or radiology. It's suggested that people should have clinical assessments at 0, 4, 12, 22 weeks and then every 16 weeks or urgently if they become unwell. I think that's very reasonable. And some services run virtual biological clinics, so that might be over the phone and looking at their blood tests that they've had reviewed. And monitoring of anti-TNF drug levels, and this is something we do all the time now, and their antibody levels, really does help to determine whether doses should increase or whether people should switch. So if you develop antibodies to infliximab and your levels are really low, then that's and your disease, your calprotectin perhaps is beginning to go up, then that's the time to swap. Don't wait to switch until people's disease is very symptomatic and they flared again. Switch them before they get sick. But you know they're going to get sick if they've got low levels of the drug and they've got antibodies and their calprotectin's rising. So we're talking a whole other talk in terms of biomarkers. In terms of side effects and contraindications, there's some really good patient information sheets on the NAC website. Always when you're starting people on drugs, think about what it means for them. So if they're going to get pregnant, or if they're on azathioprine and thiopurines, which increase your risk of skin cancer, do they work in the sunshine? And think about whether they've got other risks for immunocompromise. Do consider all those things. Just a few words about vedolizumab. Essentially, this works by its effect on an alpha-4 beta-7 integrin, which is specific to the gut. That integrin essentially takes mucosal addressing cell adhesion molecule 1 and interacts with it, and in so doing, that recruits lymphocytes and other inflammatory cells to the gut. And essentially, vedolizumab is an integrin antagonist. Interrupts that interaction and therefore stops the recruitment of lymphocytes to the gut. It's NICE approved for UC and Crohn's disease, but only in those who have failed other treatments. Now, I've put adult Crohn's disease here, but as you will see, actually the indications are very similar for ulcerative colitis and Crohn's. It's licensed for inducing and maintaining clinical response, inducing and maintaining clinical remission, improving endoscopic appearance of the mucosa, and achieving corticosteroid-free remission. In patients who have failed or are intolerant to anti-TNFs or immunomodulators and have an inadequate response or are dependent upon steroids. So it's another tool in the armamentarium. Side effects, you'd expect infusion reactions. There may be an increased risk of infection. Another integrin antagonist led to a number of people having progressive multifocal leukoencephalopathy. That hasn't been shown with vedolizumab, but who knows? We don't yet know about rates of malignancy. And then you can see that nasopharyngitis, headache, arthralgia and nausea, the usual suspects in terms of things that drugs do to people, are also evident. In conclusion, There's an increasing array of immunosuppressants and anti-TNF agents, along with other biologicals, becoming available to us. You can find some really good patient information leaflets at the following sites, and some more information both at Echo, NICE and BSG websites. I'd urge you to go and read those. Thanks very much for listening. I hope you have a good day. Thanks for your presumed attention, guys. As I say, if you want to review it, you can follow the link. Otherwise, thanks for your time. Bye.